I am presenting a case study. It's titled "A Rare Case of Primary Hepatic Neuroendocrine Tumor Resulting in DIC." So a little bit of the intro about neuroendocrine tumors is that they originate from chromatin cells and Kaposi cells of the neuroendocrine system. And then neuroendocrine tumors, they're usually found in GI tracts, the lungs, the pancreas. So about 60% of them occur there. And it's more common for them to metastasize to the liver versus having the liver be the primary source of the neuroendocrine tumor. So in fact, when it's a primary hepatic neuroendocrine tumor, it really only accounts for 0.3% of all the neuroendocrine NET. I'm just going to pronounce it as NET now, NET cases. So these patients, they usually come in with non-specific symptoms. It's abdominal pain, weight loss. So it's pretty hard to find, or it's hard to come to as a differential for in most cases. So for our case presentation, we have a 74-year-old man, has a history of laryngeal squamous cell carcinoma, and he status post tracheostomy and cirrhosis secondary to NASH. So he came into the ED about 3 weeks, having history of abdominal pain, loss of appetite, nausea. And so there in the ED doctor made a workup. He found that the patient had elevated liver enzymes. AST, ALTs were about 180 over 200. He had an increased ALP, GGT, lactic acid at 3.0, and he had low platelets around 120s. So this kind of painted the picture of possibly having an obstructive biliary process like gallstones. So CT was done, it was negative for key findings, and abdominal ultrasound was done. We thought there would be gallstones, but there weren't. But we did see a cirrhotic liver morphology. He has some ascites. So because it still had like a cholestatic pattern disease, we consulted GI, and GI recommended doing an MRCP, and that revealed abnormal appearance of liver once again, had nodules, but nothing to do with his biliary dilatations, no glial cholediasis. So at this point, his labs continued to worsen, and we decided to just go ahead and do a HIDA scan. Again, we saw that there's nothing wrong with the cystic duct, but there was like diminished uptake, showing problems with his liver. So at this point, we moved on. We wanted to take a better look at his liver, seeing maybe his cirrhosis was worsening. We decided to go ahead and include differentials to include infectious disease, autoimmune, drug-induced, or maybe ischemic etiologies. And those came up negative. So last resort, we went ahead and did a liver biopsy on him. We tested the biopsy. It was positive for chromogranin, keratin, synaptophysin. So this all indicated neuroendocrine tumor origin. And so now that we saw that it came from liver, we went ahead and diagnosed him with having primary hepatic neuroendocrine tumor. At this point, his two options really were just chemo or having surgical resection. However, because his condition is so poor, he wasn't a surgical candidate, and his labs continued to drop. He had low platelets, high LFTs again, and now his bilirubin continued to increase. So we were thinking maybe there was like a microangiopathic process related to DIC. At this point, the patient is doing really poor. He already 74 years old, really bad labs. His condition, clinical appearance seemed poor, so he decided to go ahead and go with comfort care. So this is important because the whole primary hepatic neuroendocrine tumor, because it's so rare, it's one, it's not thought about, and two, it is a treatable tumor. With surgical resection, those patients usually have a 5-year survival rate, maybe around 75%, with reoccurrence rate below 18%. So it's important to catch it early and treat it early. But in this case, because this man had very vague symptoms, that wasn't on the differential, and because we caught him a very poor stage, he couldn't be treated with surgery, he couldn't go through chemotherapy. So it's important because you want to be able to catch disease before there's delay in diagnosis. And it's notable because in literature, there's very little details of what causes primary hepatic neuroendocrine tumor. There's not a well-defined list of risk factors. I think our case, going through literature, there's maybe one. I wouldn't say there weren't any specific liver cases. So I think our case, as presented, it could have been related to chronic inflammation from the NASH, or it could have been just from cirrhosis. And then it's linked to DIC is also something that's interesting. It's not noted in literature really. And so this is our case presentation.